Welcome. My name is Dr. Rebecca Heist. I'm a medical oncologist at Mass General Hospital in Boston. And today we will be talking about evaluating second-line treatment approaches in advanced non-small cell lung cancer, the role of ADCs. So first, ADCs in non-small cell lung cancer. How can we link structure with mechanism of action? There are three key components of ADCs, and you see this in this diagram here. First, there's the antibody. This helps deliver the conjugated payload to a specific disease site by targeting a tumor-associated antigen. The linker is the bridge between the antibody and the payload and controls the release of the payload, hopefully as much inside of the cancer cells as possible. And finally, the cytotoxic payload. This is the chemotherapy warhead for destroying the cancer cells. There are many characteristics that we think about when we think about each of these components. And so what are the characteristics of an ideal antibody for an ADC? This includes high binding affinity to a target antigen, low immunogenicity, fast internalization, and low molecular weight. There are many different kinds of antibodies in the human body, and among the IgG subclass, there are 4 subtypes. These in general have a long serum half-life, but they have slightly different characteristics in terms of complement-dependent cytotoxicity, as well as Fc receptor avidity. In general, IgG1 is the most used antibody in ADC development. This is due to its solubility, the long serum half-life, and the binding affinity for Fc receptors. So the primary ADCs in development for the treatment of patients with advanced lung cancer are based on the IgG1 architecture. What about the antigen target? There are multiple characteristics that we think about for an ideal antigen target for an ADC. The antigen should be overexpressed on the cancer cell surface as compared to healthy cells. There should be an external-facing binding site. The antigen should be absent from the systemic circulation, and the antigen should internalize the bound ADC into the cancer cell. Many antigen targets are currently being developed and used in ADCs in lung cancer. These include HER2, HER3, TROP2, CEACAM5, MET, Nectin-4, tissue factor, and EGFR, and there are many other antigens that are being explored in ADCs as well. Next, the linker molecule. Characteristics of an ideal linker molecule for an ADC include the prevention of aggregation of the ADC, and also the linker should prevent premature release of the payload in the systemic circulation. There are both non-cleavable and cleavable linkers that are used. The non-cleavable linkers tend to be thioesters. These tend to be more stable in the systemic circulation because the drug release mechanism really relies on lysosomal degradation for release of the payload. The cleavable linkers tend to be acid-labile peptides or disulfides. These are less stable in the systemic circulation, and the drug release is based on physiologic conditions in the tumor environment. Shown here is an example with trastuzumab deruxtecan. This is an example of a cleavable peptide linker, and you can see that in response to protease digestion, the cytotoxic payload gets released. There are many factors that affect the stability of payload release. This can include conjugation site chemistry, the length of the linker, as well as steric hindrance at the cleavage site. And finally, the cytotoxic payload. What are the characteristics of the ideal payload for an ADC? The cytotoxic payload should be potent. It should be stable in the systemic circulation. There should be high solubility, low immunogenicity, small molecular weight, and there should be a functional group that allows for conjugation as well as membrane permeability. There are many different cytotoxic payloads that are currently being used in ADCs in non-small cell lung cancer. These include microtubule inhibitors such as emtansine, raftensine, and vedotin. There are also topoisomerase 1 inhibitors that are used, such as deruxtecan and govitecan. So how do ADCs work? This cartoon is a schema that shows the ADC comes in, the antibody binds to the target antigen, the ADC is internalized into the endosome, there's payload release of the cytotoxic warhead inside the lysosome, and then the cytotoxic warhead exerts its effects, and there can also be bystander effect, where the warhead diffuses out through the membrane to neighboring cells. So when we think about the ADC structure and how it affects efficacy and toxicity, there are various considerations to keep in mind. First, in terms of efficacy, the ADC can possess both direct and indirect anti-tumor activity. The drug-to-antibody ratio is important to think about, and we generally think about a higher DAR as being associated with higher efficacy. And the bystander effect, where the cytotoxic payload diffuses out to neighboring cells, can have an impact on efficacy as well. However, there are safety considerations to take into account as well, and some of these factors act a bit like a double-edged sword. So for example, a high DAR, which we think of as associated with high efficacy, may also have an impact on the adverse event profile. Again, the bystander effect, where the cytotoxic warhead diffuses out to neighboring cells and affects cell kill, is great if you're killing cancer cells, not so great if you're killing normal healthy cells. Premature payload release in the systemic circulation is a factor that affects safety, and inadequate linker stability, which is related to that, also affects safety and adverse event profiles as well. So why would we use ADCs in patients with advanced non-small cell lung cancer? Well, in terms of the systemic therapies that we have, the benefits of chemotherapy are limited by a narrow therapeutic index. ADCs, because the antigen-independent uptake of the cytotoxic payload in antigen-negative cells is limited, this contributes to a wider therapeutic index that we see with this class of molecules. Chemotherapy is non-selective, and this can lead to systemic toxicity. ADCs combine the specificity of monoclonal antibodies with the cytotoxicity of chemotherapy to deliver the payload directly to the cancer cells. The blood-brain barrier can limit intracranial drug delivery, and the bystander effect that we see with some ADCs may facilitate the antiproliferative activity behind the blood-brain barrier. And finally, all of our treatments, chemotherapy, targeted therapy, immunotherapy, are linked to acquired resistance, and ADCs may offer a therapeutic benefit in patients with acquired resistance to current therapies. So what are the mechanisms of resistance to ADCs? A variety of mechanisms have been described. Some of these may be related to the antigen. There may be reduced antigen expression on the cancer cell surface. There may be a truncated form of the antigen ectodomain that limits the ability of the ADC to bind. Tumor heterogeneity in terms of the expression of the antigen may affect resistance as well. Some resistance may be related to the payload. There may be increased expression of drug efflux pumps. There may be mutations in the payload target itself, affecting its ability to do its work. The mechanism of action may be affected, and this may relate to impaired internalization of the ADC itself or impaired function of the lysosome in terms of degrading the ADC. And finally, there may be activation of signaling pathways that affect the ability of these ADCs to exert their effect. There are multiple ADCs that are currently in development in advanced non-small cell lung cancer. These include drugs such as trastuzumab emtansine and trastuzumab deruxtecan, which are HER2-directed ADCs, and you can see in this table the antibody, the linker, and the payload, as well as the DAR of each of these ADCs. Patritumab deruxtecan is a HER3-directed ADC. Sacituzumab govitecan and datopotamab deruxtecan are both TROP2-directed ADCs. Tloso-V is a c-MET-directed ADC, and tusimumab ravtansine, again, CEACAM5. I'll note that trastuzumab deruxtecan is the only ADC in this table that currently has an FDA approval, and this is for patients with advanced lung cancer with HER2 mutations. There are many trials looking at these ADCs that are currently ongoing, and this includes the range of trials from phase 1 to phase 3. And again, approved in lung cancer is trastuzumab deruxtecan in HER2 mutant non-small cell lung cancer. So in summary, ADCs comprise 3 key components. There's an antibody, a cytotoxic payload, and a linker molecule. The ADCs target antigens that are expressed on cancer cells compared to healthy cells, and each component of an ADC can be modified to try to optimize the therapeutic benefit. One ADC, trastuzumab deruxtecan, has been approved for use in patients with pretreated non-small cell lung cancer with HER2 mutations, and there are many, many more ADCs that are in clinical development. Welcome back. In this section, we'll be talking about ADCs in the second-line setting, exploring the latest clinical trials data. So first, the latest data for trastuzumab deruxtecan. Remember, this is a HER2-directed ADC, and here we see the schema for the DESTINY-Lung01 study. In this phase 2 study, adults with advanced non-squamous non-small cell lung cancer with either HER2 overexpressing or HER2 mutant lung cancer were enrolled. Patients with asymptomatic brain metastases were eligible, and all patients had to have a good performance status. Patients were treated with IV trastuzumab deruxtecan at 6.4 mg/kg every 3 weeks, and the primary endpoint of this study was the overall response rate. In the population with HER2 mutations, the ORR was 55%. In terms of the safety profile, the most common any grade drug-related AEs were nausea, fatigue, and alopecia, and there was a 26% rate of drug-related ILD in this study. And so here we see the data for DESTINY-Lung02. In this phase 2 study, patients with HER2 mutant advanced lung cancer who had previously received platinum chemotherapy, again, stable asymptomatic brain mets were allowed, patients had to have good performance status, were enrolled in 2 different doses of trastuzumab deruxtecan, the 6.4 mg per kg that we saw with DESTINY-Lung01, and a lower dose at 5.4 mg per kg. And here we see, in terms of the primary endpoint, the confirmed overall response rate at the 5.4 mg per kg dose, an overall response rate of 49%, at the 6.4 mg per kg dose, an overall response rate of 56%. Importantly, the adverse event profile looked better with the lower dose. The rates of grade 3 or higher treatment-emergent adverse events was 39% at the 5.4 dose, 58% at the 6.4 dose, and the drug-related ILD rate was 13% at the 5.4 mg per kg dose, while it was remaining at around 28% at the 6.4 mg per kg dose. We saw recently the latest data from the DESTINY-Lung01 and Lung02 studies, and these were pooled data looking at intracranial activity. This was a post-hoc analysis, pooling the data in both of these studies and looking at patients with and without brain mets. And you can see from DESTINY-Lung02, the 5.4 mg per kg dose level, there were 32 patients with brain mets. And then pooled between DESTINY-Lung01 and 02, the 6.4 mg per kg dose level, 54 patients with brain mets. And here we see the efficacy in the CNS, the intracranial overall response rate at the 5.4 mg per kg dose level of 50%, and at the 6.4 mg per kg dose level of 30%. And at both of these dose levels, a reduction in the brain size lesions from baseline in the vast majority of patients. We're going to move on now to datopotamab deruxtecan. As a reminder, this is the TROP2 ADC. And here we see the Tropion Pan-Tumor01. This was the dose escalation and expansion study across multiple different solid tumor types. And specifically, there was an expansion in advanced non-small cell lung cancer. There was no minimum level of TROP2 expression required for this study. Patients with clinically inactive brain metastases were eligible. And again, patients had to have good performance status. Patients were treated with 3 different dose levels at this expansion of datopotamab deruxtecan: 4 mg per kg, 6 mg per kg, 8 mg per kg, given every 3 weeks. The primary endpoint was safety and tolerability, and determination of an MTD and determination of a recommended dose for expansion. The maximum tolerated dose defined in this study was 8 mg per kg every 3 weeks, and the 6 mg per kg dose was selected for development. And you can see here the response rate at the 6 mg per kg dose, 26%, the duration of response, about 10.5 months, median PFS, 6.9 months, and median OS, 11.4 months. We saw recently data from TROPION-Lung05. This is a phase 2 study specifically looking at datopotamab deruxtecan in patients with actionable genomic alterations. Again, patients with advanced lung cancer who had progressed on or after at least one targeted kinase inhibitor and after platinum-based chemotherapy, who had an actionable genomic alteration and good performance status, received IV datopotamab deruxtecan at the 6 mg per kg dose. The primary endpoint of this study was confirmed overall response rate, which was 36% in the study as a whole. The majority of patients in this study had EGFR mutations, 57%, and in that population, the confirmed response rate was 44%. The most common grade 3 or higher treatment-emergent adverse events included stomatitis, anemia, and elevated amylase. The rates of drug-related ILD were relatively low. They tended to be low-grade, 3% at grade 1 or 2. There was a 1% grade 3 or higher ILD reported in this study. TROPION-Lung01 is the latest data with datopotamab deruxtecan. As a reminder, this is the study schema shown here. This was a phase 3 study. Patients with advanced non-small cell lung cancer were enrolled. Both actionable genomic alterations and the absence of actionable genomic alterations were allowed. Patients had to have good performance status, and asymptomatic or stable and treated brain mets were eligible. Patients were randomized to one of 2 arms: the IV datopotamab deruxtecan at 6 mg per kg given every 3 weeks, or IV docetaxel 75 mg per meter squared given every 3 weeks. And you can see the results here. The overall response rate for datopotamab deruxtecan was 26%, while the overall response rate for docetaxel was 13%. The median PFS in the overall population was better in the datopotamab deruxtecan arm, 4.4 versus 3.7 months. This PFS benefit was driven by the non-squamous histology, and in the non-squamous subset, the median PFS was 5.6 months for datopotamab deruxtecan, while being 3.7 months for docetaxel. This was not seen in the squamous cohort, where in patients with squamous histology, datopotamab deruxtecan did not do better than docetaxel. What about safety? This slide shows the treatment-related AEs that were seen with this study, and you can see in light orange the AEs that were grade 1 or 2, and in dark orange are the grade 3 or higher AEs. With datopotamab deruxtecan, you can see that the most common AEs that were seen included stomatitis, nausea, alopecia, decreased appetite, and asthenia. Most of these were low grade, and you can see the rates of ILD here, 5% grade 1 or 2, 3% grade 3 or higher. With docetaxel, you can see the most common AEs included alopecia, neutropenia, anemia, diarrhea, asthenia. Neutropenia, notably the grade 3 or higher, was significant at 23%. And the rates of ILD here, we do see a small but notable rate of ILD with docetaxel as well. In terms of dose delays, reductions, interruptions with these drugs, we can see that with datopotamab deruxtecan, there was a 17% rate of dose delay, 11% with docetaxel. 20% of patients receiving datopotamab deruxtecan had a dose reduction, compared to 29% with docetaxel. 8% of patients on the Dato-DXd arm had discontinuation of the study drug due to a treatment-related AE, as compared to 12% on the docetaxel arm. And the rates of death due to treatment-related AEs was low in both arms. Sacituzumab govitecan is another TROP2 ADC. Here we see the IMMU-13201 study. This was a single-arm expansion of an initial basket trial. Here, patients with metastatic squamous or non-squamous non-small cell lung cancer were enrolled. Patients had to have at least one prior line of therapy. There was no pre-selection on the basis of TROP2 expression. Patients had to have good performance status, and they received IV sacituzumab govitecan either at 8 mg per kg or 10 mg per kg on days 1 and 8 of a 21-day cycle. The primary endpoint was a confirmed overall response rate, and that was 17% in this study. The most common any grade AEs, regardless of causality in all patients, included nausea, diarrhea, and fatigue. And the most common grade 3 or higher adverse events, regardless of causality, included neutropenia, leukopenia, and pneumonia. Let's move on to patritumab deruxtecan. This is a HER3-directed ADC, and here we see the schema for HERTHENA-Lung01. In this phase 2 study, patients with advanced non-small cell lung cancer with EGFR activating mutations, either an exon 19 deletion or L858R mutation, were enrolled. Patients had to have at least one prior EGFR TKI and at least platinum chemotherapy in any sequence as prior therapy. Patients with asymptomatic, clinically inactive, or treated brain metastases were eligible, and patients had to have good performance status. There was initially an up-titration regimen of patritumab deruxtecan, which was ultimately stopped in most patients in this study, enrolled at the 5.6 mg per kg every 3-week dose level. And here we see the efficacy data. Among all patients, the overall response rate was 30%. This response rate was quite similar among patients with a history of CNS metastases, as well as patients without a history of CNS metastases. And the disease control rate was quite high across the board, 70% or higher. We saw recently data regarding the intracranial responses in patritumab deruxtecan. And in the study, the phase 2 study that looked at IV patritumab deruxtecan at 5.6 mg per kg, there were 95 patients who had brain mets at baseline. And among those, 30 had not had irradiation to the brain met. And we can see the CNS response rate down below. Among all patients with baseline brain mets, a 20% CNS response rate. Among patients with non-irradiated baseline brain mets, a 33% response rate. And again, the CNS disease control rate overall, very high, 80% and 77%. What about the safety data in the population as a whole? You can see again in light orange, the grade 1 to 2 adverse events, and in dark orange, grade 3 or higher. And the most common AEs that we see here, nausea, thrombocytopenia, decreased appetite, neutropenia, constipation. There is a rate of ILD that we see with this drug as well. One patient who had a grade 5 ILD event. What about dose interruptions? About 40% of patients had a dose interruption on study. 21% had a dose reduction. There was discontinuation only in 7% and a 2% rate of death related to treatment-related AEs in this study. We're going to move on now to telisotuzumab vedotin. This is a MET-directed ADC, and the Luminosity study is shown here. This is a phase 2 study looking at patients with advanced non-small cell lung cancer who received prior lines of therapy, and c-MET overexpression was measured by IHC. Patients had to have good performance status, and there was both a c-MET high, where the IHC expression was at least 50% 3+, or a c-MET intermediate, where there was a range of 25 to 50% 3+ IHC expression. And all patients received Teliso-V at 1.9 mg per kg every 2 weeks. And here we see the response rates. In the EGFR wild-type subset, Among those with high MET overexpression, the response rate reported was 52%. Among those with medium intermediate expression, the response rate was 24%. We have seen in a press release updated results on these data that adjust these numbers somewhat, and we're looking forward to seeing the full data set soon. What about safety in the population as a whole? The most common any grade AEs reported are peripheral sensory neuropathy, nausea, and hypoalbuminemia. There were grade 5 AEs that were possibly related to Teliso-V. This included sudden death in one patient and pneumonitis in one patient, and both of these deaths occurred in the squamous population. And then finally, touchIME ravtansine. This is a CEACAM5 ADC. In this study, patients with previously treated non-squamous lung cancer with high or moderate CEACAM5 expression were enrolled, received IV touchIME ravtansine at 100 milligrams per meter squared every 2 weeks. The primary endpoint was response rate. In the moderate expressors, a response rate of 7%. In the high expressors, a response rate of 20%. The most common treatment-emergent adverse event in patients treated included corneal events. There are many ongoing clinical trials of ADCs in non-small cell lung cancer, and this table shows just some of them. This shows some of the second-line approaches that are being looked at. So, implications of the data that we reviewed. More research is required to really optimize patient selection, to determine what the optimal sequence of ADCs really is, develop strategies for patients with acquired resistance, and to confirm the signal of activity that we're seeing in patients with brain metastases. Welcome back. ADCs in clinical practice. How can we optimize treatment for patients with advanced and metastatic non-small cell lung cancer? Shown here are multiple different ADCs that are currently in clinical development or being used in non-small cell lung cancer and their antigen targets. As a reminder, trastuzumab deruxtecan is the one ADC here that in lung cancer currently has an FDA approval, and that is specifically among patients with lung cancer with HER2 mutations. It is, though, also used and has been studied in HER2 overexpression as well as amplification. We also see trastuzumab emtansine. This does not have an FDA approval specifically in this indication, but is listed in the NCCN as a potential recommendation used in HER2 mutation, HER2 amplification, and overexpression. Patritumab deruxtecan is an ADC directed against HER3. Datopotamab deruxtecan and sacituzumab govitecan are ADCs directed against TROP2. Telisotuzumab vedotin is an ADC directed against c-MET. And touchIME ravtansine is an ADC directed against CEACAM5. Can we refine selection of patients for ADCs? And when we think about things, we think about, is there a biomarker that we can use? And trastuzumab deruxtecan gives us a good example of a biomarker-directed approach. We know that in non-small cell lung cancer, there are about 1 to 4% of patients who have a HER2 mutation. A slightly higher proportion of patients, 2 to 30%, have HER2 overexpression. And when we look at the DESTINY-Lung01 study, this included patients in 2 different cohorts, HER2 mutated advanced lung cancer or HER2 overexpressing advanced lung cancer. And to the left, you can see in the HER2 mutant population, an overall response rate of 55%, a disease control rate of 92%. In the HER2 overexpressing lung cancer population, an overall response rate of 27% and disease control rate of 69%. The approved dose, as you know, is 5.4 mg per kg. There, the overall response rate in the HER2 mutant population was 49%. And trastuzumab deruxtecan gives us an example of an antibody-drug conjugate where it can use a biomarker, in this case HER2 mutation, to really select who is going to have the most benefit. However, it can be difficult to actually find a biomarker. Sacituzumab govitecan and the TROP2 ADCs in general we think of as a biomarker agnostic approach. We know that there's high levels of TROP2 expression in lung cancer. This has been reported to be about 64% in adenocarcinoma, 75% in squamous cell carcinoma of the lung, where there's TROP2 overexpression. But when we look at the efficacy data, there's not a clear correlation between TROP2 expression and efficacy. In the IMU-132-01 trial, there was no preselection based on TROP2 expression. The overall response rate, as you see, was 17%, with a clinical benefit rate of 43%. But there is no correlation between the patient outcomes and the level of TROP2 expression. And it's unclear at the current time whether we can use TROP2 as a biomarker, as the studies so far have not shown a correlation between response and TROP2 levels. So patritumab deruxtecan, this is a HER3-directed antibody-drug conjugate. And remember, this drug has been studied in patients with lung cancer with resistance to EGFR TKIs. But when we look at the HER3 itself and HER3 expression, all tumor samples in this study, in the phase 1 study, demonstrated HER3 expression. but confirmed responses were seen across a wide range of baseline HER3 H-scores, so no clear correlation between the level of HER3 expression and efficacy. And in the phase 2 data, again, this confirmed that there was efficacy and responses seen with patritumab deruxtecan independent of HER3 expression, and also across many different mechanisms of EGFR TKI resistance. Sometimes, though, overexpression does matter, and we see here examples with Teliso-V and tuzomitamab riftanzine. You see the high c-Met expression, 35% response rate, with the intermediate 23% response rate, and then with CEACAM5, high CEACAM5 expression, 20% response rate, moderate CEACAM5 expression, 7% response rate. And so antibody-drug conjugates such as this suggest that the level of overexpression of the target antigen may be important when we think about should we be selecting based on specific biomarkers. We also select based on toxicity, and we should think carefully about toxicity and how it occurs and why it occurs. And payload-mediated off-target mechanisms drive the majority of ADC toxicities. Shown here is a schema showing one of the many ways that off-target toxicity can occur. There can be premature deconjugation of the cytotoxic payload from the ADC that then passively diffuses into non-target healthy cells, causing cell death. There may also be non-specific endocytosis, and here the intact ADC may contribute to off-site delivery of the payload, again causing cell death in a non-target healthy cell. Receptor-mediated endocytosis can be seen. Here we're talking about uptake of the intact ADCs into healthy cells through binding to FC or C-type lectin receptors. This ADC then is internalized into a non-target healthy cell, and the payload release leads to cell death. There may also be target-mediated endocytosis. Here the ADC is internalized into a healthy cell through binding of the target antigen that's expressed on the cell surface. And again, then the ADC exerts its effect on a non-target healthy cell. Bystander effect may also occur, and here this can exacerbate the off-target toxicities through increased diffusion and distribution of the payload into normal tissues. So let's think about the adverse events that have been reported with ADCs. And one thing to note is that the spectrum of adverse events is not just constant across these various ADCs. They all have a slightly different AE profile. Shown here is a diagram showing the gastrointestinal effects that are commonly reported. And to just orient you to this figure, in gray is the sacituzumab govitecan data, in dark orange, Teliso-V, in light blue, trastuzumab deruxtecan, in light orange, patritumab deruxtecan, and in very dark navy, datopotamab deruxtecan. And you can see the most common any grade AEs that are GI in nature include diarrhea, constipation, nausea, decreased appetite, stomatitis, and vomiting. And when you look at the distribution of these AEs among the different ADCs, you can see that they congregate slightly differently. For example, diarrhea, the rate is highest with sacituzumab govitecan. Stomatitis is something that seems relatively unique to datopotamab deruxtecan. And when you look at the rates of grade 3 or higher AEs with at least 5% incidence, you can see diarrhea and nausea are the ones that we see with sacituzumab govitecan, stomatitis with datopotamab deruxtecan. What about hematologic side effects? We can see cytopenias with these ADCs, anemia, thrombocytopenia, leukopenia, neutropenia, and you can see the rates of these by the different ADCs, again color-coded in the same way. And here I'll note that we see an absence of really much in the way of hematologic AEs with datopotamab deruxtecan as compared to some of these other ADCs that are shown here. What about the rates of grade 3 or higher AEs that are hematologic in nature? With at least 5% incidence, you can see anemia, thrombocytopenia, neutropenia, leukopenia, all seen. And again, relatively fewer cytopenias seen with datopotamab deruxtecan as compared to some of these other ADCs where we do see cytopenias, and it is something we need to be aware of. Pulmonary AEs can happen. We know that ILD is an adverse event that can happen. Specifically, we see this reported with trastuzumab deruxtecan, patritumab deruxtecan, and datopotamab deruxtecan. We see a rate of pneumonia with sacituzumab govitecan. In terms of grade 3 or higher, we see pneumonia with sacituzumab govitecan. And then other constitutional symptoms, such as asthenia, fatigue. Alopecia is one that's important to know about and to warn your patients about. Anorexia, rash. We can see that the range of AEs that's seen is different, and we really need to pay attention to which ADC we're using to think about which AE should I be watching out for. For example, we see with Teliso-V, there's peripheral sensory neuropathy and hypoalbuminemia as a common any grade AE that's seen, not seen so much with the other ADCs. And then common constitutional AEs reported. Fatigue is one that we see quite a bit with ADCs, as you might expect. There are potential class effects of the cytotoxic payload regardless of the antigen target. And so when we think about things, we think of the auristatin. MMAE, for example, has been associated with cytopenia such as anemia and neutropenia, peripheral neuropathy, and skin toxicity. MMAF associated with ocular toxicity, thrombocytopenia, hepatic toxicity. Among the maytansinoids, DM1 has been associated with thrombocytopenia and hepatic toxicity. DM4, ocular toxicity, cytopenia such as neutropenia and anemia or peripheral neuropathy. And then the camptothecans, deruxtecan associated with pulmonary toxicity, govitecan with neutropenia and diarrhea. The toxicities are not always predictable. Two ADCs with the same payload, similar linkers, similar antigen targets, similar DARs can have different toxicity profiles. And it's really important to know the AE profile of each ADC as you're using it so that you can manage it the best for your patients. Let's talk a little bit about ADC-associated ILD. This is something that's been reported across phase 1, 2, and 3 trials. And you can see here with trastuzumab deruxtecan, any grade ILD reported at 13%, grade 3 or higher, 2%. With datopotamab deruxtecan, any grade ILD at 8%, grade 3 or higher, 3%. And patritumab deruxtecan, 5% any grade ILD, 1% grade 3 or higher. And as you're using ADCs such as this, consideration of this is important so that we can minimize the risk of the impact of ILD. How do we do that? One is to screen. We need careful patient selection so that we are screening patients appropriately for treatment with these drugs. And we also screen during treatment. We need regular clinical assessments to exclude ILD. Scans are a key part of this. So radiographic scans are fundamental for diagnosis of ILD. We prefer high-res CT scans of the chest. And we should have a baseline scan as is repeat scanning every 6 to 12 weeks. Synergy. We need to synergize with the patient and the care team. We need to educate patients so that they know what to watch out for. We need to involve a multidisciplinary team to manage the ILD once it's suspected. Suspend. The ADC should be interrupted if ILD is suspected and restart only if it was asymptomatic ILD that's fully resolved. And then steroids are the backbone of treatment, and the dose of steroids is really adapted to the grade of the toxicity. It's important that we balance efficacy with safety and quality of life. And when we look at different dose levels of drugs, as was done in the TROPION-PanTumor01 study, this is what we're thinking about. We're thinking about how can we get the best efficacy results while we maintain the AE profile in a way that's manageable for patients. And here we can see the response rates across different dose levels that were tested. We can see the rates of grade 3 or higher treatment-emergent adverse events. And based on this composite data, the 6 mg/kg dose was determined to have the optimal benefit-risk ratio. So future considerations for ADCs in non-small cell lung cancer. When we think about how we treat a patient with non-small cell lung cancer, if a patient has in their tumor HER2 mutation, we would do first-line systemic therapy, and then at progression, we have options of ADCs. Remember, trastuzumab deruxtecan is approved in this setting. Trastuzumab emtansine is another HER2-directed ADC. There are studies looking at, in patients with advanced lung cancer with HER2 mutations, can ADCs such as this be moved into the first-line treatment setting? And this is still an open question. And then other advanced non-small cell lung cancer, should we be looking at other levels of overexpression, other mutations to think about some of these other ADCs, or in a biomarker agnostic fashion, thinking about the use of some of these ADCs? And here, these are not approved, but they're currently in clinical development and being tested actively. So when we think about the future, one question that always comes up is, can these ADCs be moved in the first-line setting? And there are multiple clinical trials looking at this, and this shows just a few of the trials that are currently ongoing. So in summary, ADCs can be selected for use both in a biomarker-guided and biomarker-agnostic approach, and this depends on the specific ADC that we're talking about. There are multiple mechanisms of off-target ADC uptake that are thought to drive the majority of ADC toxicities. The toxicities are not always predictable. Similar ADCs with similar structure can have different toxicity profiles. The 5 S's are important to think about when we think about minimizing and managing ILD, and there are recommendations in place for managing ILD when it's suspected. And the role of ADCs is rapidly evolving in both the second-line setting as well as the first-line setting, and I expect that we'll see much new data in the months and years ahead.